All right, good afternoon, everyone. Welcome and thank you for joining the working session on the reporting of electronic healthcare transactions as required by Chapter 790, 791, Public Health, State Designated Exchange, Clinical Information. Before we begin today's working session, I have a few housekeeping notes. If you experience any technical difficulties during the call, please contact my colleague, Justine Springer. Her contact information is available in the chat. Today's meeting is being recorded. And on today's call, I have a colleague with me, Mac Benro. Mac will be supporting our team on the implementation of the law. I'd like to introduce everyone to Mac, as you may receive correspondence from him in the coming months.
Hello, everyone.
So we are looking forward to having a robust discussion during today's working session. Until we get to the discussion portion of the meeting, please remember to mute yourself. We will not be holding a formal roll call today, but we're really excited to have around 55 people register for today's working session, including representatives from 12 HIEs and 10 EHNs. And since we're not going through roll call during the discussion portion of today's call, please introduce yourself and your organization. You're also welcome to update your name on Zoom to indicate your organization. And we've noticed sometimes if you receive a registration link from someone, you may have entered the Zoom under a different name. So just double check your name to make sure it's correct. And the chat feature for today's meeting is on, and we encourage attendees to participate in today's discussion. But please keep the discussion focused on the implementation of the law and the regulations. All right, and so before we begin with today's agenda, I'd like to offer our Center Director, David Sharp, an opportunity to say a few words. David?
Sure, and thank you, and good afternoon, everyone. It's great to see you virtually, many of you. We've talked to a lot over the last several months. We're excited to ask some questions regarding a handful of comments that we received back from stakeholders on the regulations. So your feedback will help us formulate next steps for continuing this process moving forward. Don't be bashful, but at the same time, try to formulate recommendations that we can take away and in some way include or consider including them in any proposed modifications to the informal draft. It's a journey. You've all been on this with us in other ways for other regulations, particularly related to health information exchange. This one is supporting the electronic health networks. And as many of you know, there's roughly 32 of them operating in the state of Maryland. So with that, I will turn it back to my colleague, Anna Gribble, for taking us down the pathway.
Thank you, David. So let's begin with an overview of the law. Chapter 790, 791, Public Health, State Designated Exchange, Clinical Information, passed during the 2021 Maryland legislative session. The law requires electronic health networks, or EHNs, to provide electronic healthcare transactions to the State Designated Health Information Exchange, CRISP, for public health and clinical purposes. Now, electronic healthcare transactions include transactions that have been approved by a nationally recognized healthcare standards development organization to support healthcare informatics, information exchange, system integrations, and other healthcare applications. The law prohibits EHNs from charging fees to healthcare providers, healthcare payers, or to CRISP for reporting these transactions. And CRISP is required to develop and implement supporting policies and procedures for submitting electronic healthcare transactions. The law aims to expand statewide public health capabilities, including facilitating a state health improvement program, mitigating public health emergencies, improving patient safety, as well as offering healthcare providers a more comprehensive view into their patient's medical record. So in the fall of 2023, MHCC worked with CRISP and certain EHNs to explore potential implementation approaches for Chapter 790, 791. And these conversations built upon a pilot that was previously hosted to identify potential implementation options. And then a recent version of the regulations were released for informal public comment in May, and we received 15 unique comments on COMAR 102507 certification of electronic health networks and medical care electronic claims clearinghouses related to the reporting of electronic healthcare transactions. Now, these comments, they had a few different themes that came about, including potential uses of the data, clarification on reporting requirements, and timelines. So for today's working session, we will review and discuss amendments to COMAR 102507 and consider possible strategies for implementation that build upon existing technology and processes. So we appreciate everyone who reviewed the regulations this spring and provided comments. So shortly, I'm going to pull up the draft regulations and we're going to walk through the proposed changes. I will add comments or suggested edits to the regulations as we discuss your feedback. And during our discussion, we will also take a moment to identify what are those key elements EHNs recommend including in a form of a technical reporting. So I will pull up the regulations now. All right, so these are the draft regulations that people were able to review earlier in May. I have in front of us Chapter 7, Regulation 9, which is where a lot of the edits regarding the reporting of electronic healthcare transactions begin. And I'm just going to go through this section by section, and we'll have an opportunity to review it and discuss. And we look forward to hearing your input on implementation strategies or potential considerations for the regulations. So starting with Regulation 9, Section A. Section A discusses that electronic healthcare transactions reported to CRISP can be used for certain purposes, including a state health improvement plan, mitigation of public health emergency, or improvement of patient safety. Now, these use cases come from the law, but we would like to hear from those on the call. Are there any questions or feedback on this portion of the regulations? I can give you a minute to read it as well.
So Anna, just to restate, we're asking folks if there's any questions around 09A 1, 2, and 3. If there's anything that they'd like to add or offer up, we're happy to record it and take it down and use it as a takeaway to talk further. And I see Genevieve Morris has her hand up. Genevieve, good afternoon.
Hey, afternoon. I'm with Optum. So I believe in our comment letter, we mentioned that in the legislation, it actually states that MHCC would be providing further definitions of what these 3 items are. And we were a little bit surprised that the proposed regulation did not have any further defining of these 3. So I think, we have some concerns about, what these 3 use cases actually entail and what the data would be used for under any of these 3.
So we're going to be taking notes. Some of this we won't have an immediate answer for. I seem to recall this came right out of the legislation, and I don't recall seeing, and I'm looking through the bill now, and we have our attorney, or the assistant AAG, Alexa Bertinelli, who, Alexa, if there's a point you can make here, that would be great. Otherwise, we'll take it as a takeaway.
I don't think I have anything to add right now. I mean, we can take this back and review it.
Yeah, I'd like to respond, David, to Genevieve's comment. I mean, I think I understand what data suppliers are thinking here. I think in thinking back over the legislation, the legislature thought that we needed to have some broad definitions to capture potential use cases. I think the state health improvement programs definitely includes, statewide initiatives that would be launched by the state of Maryland in collaboration with perhaps the federal government. What comes quickly to mind is all of the work that's gone on here in the past nearly 15 years since the original rate setting system was replaced by various demonstration projects. And that is, clearly one area that I think we recognized would be important to define. I think whether we spell out that it is the head model or the total cost of care model, I think we'll rely on our attorneys to put that together, but I understand, your interest there. In terms of the public health emergencies, obviously that was in the midst of the COVID-19 pandemic. It's still with us on a more managed process, but it hasn't gone away. But I would anticipate that we would add some clarity there. And we just got off the phone actually, or off a meeting where we talked about our work with the Maryland Patient Safety Center. That doesn't directly hinge on any data coming from electronic health networks at this time, but it could. But I think clearly what the legislature had in mind was to support the very important, critical total cost of care, and soon to be a head model would fall under that first category for sure.
And Ben, while you're talking, good afternoon again, everyone. Just so you know, many of you know the staff here, but Ben is our executive director of the organization. Ben, there's a question here you may want decide to field or redirect, and that is from Eric Grinstaff. The question is, one, does this include Medicare, ERISA, and data for which the EHN does not have a direct relationship with a payer?
So I think it depends on the use case that we're talking about, but I guess I would be curious as to what Eric means by not having a direct relationship with the payer.
Eric, are you able to weigh in?
Yeah, sorry, bear with me. I've got a bit of a cold.
No worries. And Eric, where are you from, please?
Sorry, I'm from Paradigm Payer Path.
Thank you.
So clearinghouses will typically have multiple relationships with other clearinghouses, as you may have seen with the recent security issues that we all had to work around. We typically utilize each other's networks to make sure that we have adequate coverage for the payers that we're trying to reach. So you might have a claim that originates with a provider that goes to Clearinghouse A, and then it's sent to Clearinghouse B in order to make it to the end payer. If Clearinghouse A and Clearinghouse B are both submitting all their data for that provider, then you would have a duplicate of the information on that claim, and potentially the reports and remittance advice coming back as well.
So, Ben, if I could just offer a thought. We are planning at the conclusion of this discussion to talk further about what should be in a technical manual. And I believe this fits well because the thinking originally was that the transactions would be coming from the provider, and upon receipt to the EHN, they would then be forwarded on, or part of that file that would be sent to Chris. It wouldn't be looking to capture what some might have called an EHN in the middle, or working both ends to the middle, meaning from the same transaction that you send to the payer from the provider and back would be the same. It would create duplicity, if you will. So it's It's anything to the endpoint or from the endpoint. And the endpoint we thought about in discussions with you all would be the payer, excuse me, the provider. So, please stick around, Eric, for our technical discussion, so we can talk further about that.
Yeah, that's definitely an interesting clarification. Thank you.
You bet. So Ben, another question, and I'm not necessarily suggesting you field it, but I invite you to do that. One of the questions from Genevieve Morris is on the use case definition. The concern for change is that is knowing that CRISP is using the data for only the purposes stated in the law, because there's concerns around legal liability when the data gets handed off.
So what is the question? I mean, I think we obviously would look at the broad use cases here to make sure that any use of the data conform to specifically to one of the three outlined above, but I'm not sure what Genevieve, could you elaborate?
Yeah, and I also dropped into the chat the statutory text where we believe it says MHCC has to further define these three purposes. I think without a further definition, there's a level of uncomfortableness, to be quite frank, that we're handing off a incredibly large amount of data on an ongoing basis with really no understanding of, other than like these very broad statements, how that data is going to be used. And if there was to be a lawsuit of some sort because something, a patient doesn't like any of this, right? We wouldn't be able to have any understanding of whether something falls into those three without actual definitions in the regulations, much like HIPAA defines, things like public health, right? So I think our expectation is that there would be standard definitions to ensure that there is compliance with the law on the part of CRISP, and that we have, a little bit more reassurance around our legal liability for this.
Yeah, all right. No, thanks for that clarification. I think we'll go back and think through how that can be operationalized in these regulations.
Thanks, Genevieve.
Thank you.
Any other questions before we move on? Okay, thanks. Anna, back to you.
All right, thank you, everyone. We're going to move on to section B, and we're going to focus on the first two subsections for this discussion. I'm going to highlight those so it's easy for people to identify them. So this portion of the regulations further specifies that the transactions to be submitted to CRISP shall consist of the X12 transactions, including the 837 transactions and 270, 271 transactions, but exclude pharmacy transactions. And then subsection 2 further specifies that the data content and format requirements should align with the most recent corresponding X12 implementation guides.
So before all the hands start popping up, let me just note that we did receive a comment from an organization that made a good point. It was an oversight on our part, that in this, if we're allowing EHNs to submit files of the data, which seem to be the prevalent approach amongst the EHNs, it wouldn't be in X12 standard. So we'll make a note to clarify and remove the X12 item. It would only be X12 if we were sending it in a pathway of an 837 or 835. And what the clearinghouses have specifically asked for is the ability to send a file similar to a CSV or something along those lines. Any comment? Oh, Eric, back to you.
Yeah, just so the language here reads that EHN shall submit electronic health transactions originating in Maryland. Earlier, when you were talking about envisioning this being providers submitting to the EHN. Does that need to be clarified specifically to be transactions from providers?
So, when we think of them originating in Maryland, we would think of them coming from a provider. If you're thinking that, it would be helpful, tell us why, and we'll make a comment, we'll make a note here, and certainly give it lots of thought.
So, like I was saying earlier, we both send and receive transactions from other clearinghouses that might be located in Maryland or for payers that are in Maryland. We may also have the difference between a provider claim and a patient claim. And we would need to know, originating in Maryland is fairly vague. So
Good point, good point. We need to look at that and see how we can tighten that up.
If this is Genevieve, we agree with Eric. We're a little bit, a couple of the thoughts that we had are organizations like MedStar and Johns Hopkins and the large healthcare organizations operate in both Maryland and DC. And so, if they roll under a Maryland organization, but the office location for that particular care was provided in Maryland or provided in DC, does that count? And then some things around medications covered that are not covered under pharmacy, but are covered under medical services, where we actually were not clear. Pharmacy transactions means no medical prescriptions, even those covered by medical. So I think we would like some clarification there. But if prescriptions covered under medical are included, I think we would want some clarity around, if they're in DC getting for the office visit, but then they pick up their prescription in Maryland. Does that like where does that fall, right? There's some confusion there. And then the same thing around the payer side. Once you get to the 271s in particular, if the payer is located in Maryland, but the patient is getting care in DC or Virginia, but the payer is in Maryland, like what constitutes originating in Maryland when you're looking at the payer side of it for the eligibility? I think that was a little confusing to us as well.
Yeah, so we'll clarify that in definitions. Because we've talked about non-CVS reporting, dispensers reporting in the first working session we had. I wouldn't imagine that we would create a regulation that would create duplicate reporting. So again, this is an area where we can add definitional explanations. Good feedback. Anybody, Eric, is your hand still up, or you had a different question? I see it.
sorry, no, I agree with what Genevieve said.
Super. Anyone else have any thoughts here? Okay, good discussion. Thank you all. Anna, back to you.
All right, so moving on, staying in section B, but moving to subsection 3. Now, this portion of the regulations further specifies that the transaction submitted to CRISP shall be submitted in a flat file and a communication standard approved by CRISP. This may be a good opportunity to take a pause from discussing the regulations itself and hear from those on the call. If we were to take a similar approach of creating a technical guidance manual or submission manual for EHNs, what would you like to see included to provide an additional level of detail in a further guidance manual?
And Anna, would this be in addition to the comments that were already made regarding the definitions? We know that the definitions would be added to reg, but they would also be carried through into any sort of manual. So, so it would be things like frequency of reporting, what kind of files are acceptable, what's the transmission mode, is there a validation step that has to occur, CRISP, and so on. And we have Nicole Sweeney on the line from CRISP today. Nicole, do you have any thoughts here?
Specifically about this book? this
Sure.
manual.
Yes.
I definitely think that it has been a helpful process for the non-clinical data set, or excuse me, non-CDS, not non-clinical data set. Specifically because there are a lot of operational issues that I think are hard to dig in from a regulation perspective. And I think we're hearing a lot about those today. So I think, you know, from a CRISP perspective, we would be very open to this, whether in, you know, it's something that MHCC leads, or if there are some EHNs that would be interested in working with us on a pilot that would elucidate some of these operational issues that we would need to put into a manual. But I generally think it's a great idea to, if there's certain things that don't necessarily need to be in regulations, but are very helpful from an operational perspective, to have these types of things. I know Craig's on the line too. Craig, if you have any additional thoughts.
No, I agree with that. I mean, we're really open to developing whatever standards are useful and through whatever methods are going to work on the EHN side.
David, could you clarify for this, is the ultimate goal with the technical guidance manual that you guys are going to specify one flat file format that all of the EHNs have to follow, or that you're just going to specify, you know, like secure transmission methods, here's the data elements that have to be included? What's the kind of idea behind it? Like, what level of specificity are you going to?
So I think it's a little bit of all the above, meaning that there would be some elements of the data dictionary, what are the required reporting components, if you will, as well as with the transmission mode, a designated approach. And that's where I think what we heard Craig and Nicole say is that having a couple of EHNs that might be willing to work in a pilot mode on being able to test or vet different approaches could lead to the best pathway forward. There will be some time to do that. So I think it's something, Genevieve, maybe you guys want to consider, or Eric, you your path, you may want to consider. But what we found on the dispenser side is getting testers to help pilot this initiative. And it's just a short pilot. It doesn't run for months and months, and it certainly doesn't take hundreds of hours. It's been enormously successful, and I think Nicole echoed that.
I mean, I think, and I don't know how the other EHNs feel. I think our preference would be that you guys specify the data that has to be contained in the quarterly reports, but that you allow us to use a flat file format, like one. I think many of us already have those in existence. So really, quite frankly, to minimize the level of work on our side for something that we clearly are prohibited on getting reimbursed for. I think our preference would be, if we have an existing flat file format that contains all of the data elements required, that we be allowed to use that flat file format, just to minimize disruption to our own operations.
Yeah, and Genevieve, did you say you already have a flat file format for the 835?
We do, yes. I don't know that other EHNs do, but Optum does.
Is that something you would be able to share with us to be able to take a
Yeah,
look
so
at?
it would be the same format that we shared last year with de-identified data in it. It would be the exact same format that we would use. I would suspect each of us EHNs have a slightly different layout, right, to our flat file. Which is why I think our preference would be that we each get to use our own layout and just specify the data that has to be contained in it.
Yeah, but I think we have to sort. That's a very good point, and we need Chris to think about that as well, because do they have the ability to consume where the desire?
Yeah, and just one other note on that to think about from a cost overhead perspective is, there are a number of code sets that we are required to license for certain things, particularly from the AMA and the AHA, so CPT codes and NUBC codes. And generally speaking, like if if we have to significantly transform data and or put things into a vocabulary, that will increase our licensing costs pretty exponentially. And I think this is true for all the EHNs versus simply pulling it out and putting it into a flat file format. So the more transformation you require us to do, that just adds a lot of overhead costs for us, including on things like code set licensing.
Yeah, and originally, Genevieve, we weren't thinking of needing to remap or needing to map differently or to create a lot of customized programming. It was, what did you get? And you can put it in a file and send it forward. Yeah.
Yes, as long as there's not a requirement that we have to assign codes if something comes in without a code, I think that's fine. I just, the data's all over the place generally.
That's right.
This is Nicole Sweeney. I apologize. I can't raise my hand. I'm phone only. Would it be okay for me to ask a question?
Nicole, you broke up, but I think if you have a question, please go ahead and Eric will come right back to you.
Oh, sorry. Thank you. I can't see screen. I'm phone only. Hopefully you all can see me. I was just curious, but I think I heard somebody on the phone earlier mention that the EHNs share information with each other often, that it might start with one and then go to another, etc. So I'm curious if they're, I heard Genevieve say that everyone might have a different flat file format. I'm curious if you all have solved this amongst yourselves and sharing the data, and if maybe that's like a cheat code we could potentially use or explore.
Yeah, so
We share the X12 transactions,
Yeah.
Nicole. So
Oh,
it's,
got it.
yeah, because
Yeah,
we have trading
it.
partner agreements in place for that. And I think Eric, it's a really good point of like there's going to be duplicative stuff, I think.
Yeah, that's right. Eric, your thoughts?
A couple of thoughts. Number one, the technical guidance manual. One of the things that we need to make sure we lock down is security.
Yeah, no doubt. No doubt.
With this amount of information, and I think I know for us, I'm not sure if other EHNs feel the same, but we might want to look at different flat files by form type, or at least some indicator so that when we're translating this data into that flat file, we can keep it straight.
Yeah, and this is where the piloting piece, I'll just remind everyone the importance of having a couple folks that participate is going to be enormously helpful. It will make all of our lives easier if we have a good chance to test different options. So I think, Beth, I'm not sure we understand your question. We say, the X12 is from network to network. I think what Genevieve and others have articulated is that a flat file would be the things like the CPT codes, the HCPCS codes, just the elements of an actual claim, the coding.
Right, I'm sorry, I didn't, I was just commenting on the conversation at the time that when it comes to how we share between other covered entities, we use X12 only.
Yeah.
But we can certainly do flat file, but our existing logic is around X12 only.
And Beth, what organization are you from?
Paradigm Path with Eric.
Oh, okay, very good. All right, this has been enormously helpful. We can travel along if there are not any additional comments here. Okay, Anna, back to you.
Okay, thank you, everyone. So moving on to the last subsection of section B. And this is regarding the frequency of reporting. So the regulations specify that transactions will be reported at least quarterly to CRISP, no later than the last business day of each quarter of the calendar year. I believe we received some comments regarding specifying quarterly and what to be included, but do others on the call have questions or comments regarding this timeline?
I think you guys have our comments about the timeline from an Optum perspective and just some clarity there, but I do want to just take this opportunity to say we do have concerns related to HIPAA around submitting on a quarterly basis every single claim that has come through. And I think we've expressed this in conversations as well as in our letter. Concerns around, how HIPAA functions around limited uses of data for specific purposes versus just a handoff of a lot of data. So generally, we are concerned about submitting a quarterly file of every single claim that originates in Maryland and whether that really complies with HIPAA. I'll leave that comment there. You guys don't have to respond to it. I just want to make sure we're on the record with it.
Yeah, and we can, yes, we have that, and thank you, and maybe that's a separate conversation, because we've actually had a history of having this conversation. I think your predecessor actually, we engaged him on as well. So we're happy to have this to talk with you further if that's helpful. Okay.
Oh, go ahead, Eric.
Well, I was just going to add, I agree totally with what Genevieve's saying. And also, if there is data that you're expecting us to withhold, certainly we need to have conversations about that as well. If it's for just the purposes outlined in the beginning, if there are other data points like opt-out provisions or something like that, those things can be very difficult for us to implement, and would definitely extend out any kind of implementation timeframe. And certainly, depending on what it was, could raise additional concerns.
Understood. Thank you.
This is Beth. I don't know how much this would be a factor, but we're also talking about an enormous amount of data at one time. So getting that transported or broken up into pieces, I mean, you could be talking a couple of days to get this data from one place to another, depending on the method.
Yeah, so it might, need to be depending upon the amount of data. Of course, we don't know exactly how the data is defined yet, so we can't estimate the size of the files, but it might need to be much more frequently
In
than
a quarter, right? Million, it could be a lot of claims in a quarter.
I think we received a recommendation of by the end of the quarter, including data from the previous quarter. So by the end of Q2, submitting data from Q1 as a potential option.
Right, but regardless of which quarter it is, you might still have millions and millions of claims for that time frame. I'm just speaking for overall. Especially in a flat file that may or may not be compressed, could be rather large.
Yeah, no, that's an excellent point. Something we've thought a bit about. So it could be a question of frequency of reporting, could be a different method other than this is why we started not using the flat file approach and then went to a flat file approach to avoid the headaches with standards. And it does lead us.
A question for the networks that are on the line. Does it make any difference if it is monthly as opposed to quarterly? That presumes that the use cases are defined, but it probably would be more beneficial if we had it more timely. And hearing what a couple people said, it sounds like it might be more beneficial to you if you weren't submitting such a large bolus of data at one time.
I think just from my perspective, a lot of flexibility here is needed, because depending upon the EHN, you'd have different volumes of data to fit in that flat file, and quarterly might work for some. Others might have to do monthly or even maybe even daily, depending upon the size.
Yeah, our preference is quarterly, primarily because of the work to pull out the data and filter through it, and restrict, pull out the financial information, restrict the reproductive health information, all that stuff that we have to do. So I think we prefer quarterly because it cuts down on our file prep time. I think our only request would be if we start the transmission on the last business day of the quarter, but it might take 3 days. And I have seen that with customers, particularly recently as we were re-onboarding folks. If it takes 3 days, but we started it on the last day of the quarter, right? Is that allowable? And that's just because, for sure, we are dealing with millions of transactions.
Yeah, good point. Okay, we've noted these concerns.
And I was just gonna add that, again, it's Beth, that I don't know how you plan to do patient matching or duplicate checking or something, but that formula may change based on the frequency, because you wouldn't be able to rely on anyone else to filter out duplicates.
That is true. Anybody else have any thoughts here? Okay, Anna, back to you.
All right, so moving on in the regulations. Moving to just section C. I want to talk about this before going into the exemptions. So this regulation specifies that an EHM may not charge a fee to healthcare provider, payer, or CRIS for providing the information. And this comes from the statute itself. But before we move on to the next section of exemptions, we wanted to give people an opportunity to weigh in if they have any comments or feedback on this particular language.
Okay, hearing none.
Moving on to exemptions. Let's focus on 1 and 2. So this portion of the regulation specifies that MHCC, an EHN may request from MHCC a 1-year exemption for reporting. The exemptions must be in writing and identify specific requirements in the regulations the EHN is requesting an exemption, as well as the time period of the exemption and the reason, and include information that justifies the exemption request. Now, does anyone have any questions about the exemption process and what is required of EHNs to submit?
Yeah, I mean, it's pretty straightforward, so I don't think that I recall seeing a lot of comments about it. Happy to talk about it here. Folks have thoughts. Okay. And
We can move on. So the next portion of D is it goes over what happens when an EHN submits an exemption request. So within 45 days of receiving the request, the MHCC shall consider the request and either grant or deny. And there are specific scenarios in which, or following grounds in which the commission may grant the exception, including the absence of functionality. The requirement would hinder the ability of the agent to comply with other requirements. The requirement would cause an undue burden or hardship, and for good cause shown by the good cause shown, and the commission may renew the exemption for an additional 1 year. Are there any questions or comments on the response process for the exemption? And we didn't receive a lot of comments on this section either, just wanting to give people an opportunity to weigh in if you choose to.
okay.
Hearing none, we can move to the effective date. Oh, Eric, do you have a comment?
I've got a comment on the effective date language here. Where it says begin submitting healthcare claim or equivalent encounter information, 837P and 837I transactions. That wording is a little confusing in light of the flat file statement. I don't know if you want to consider
Yeah,
revising that to be the information contained within or something along those lines.
yeah, and I was gonna mention that this is an area that we have to tweak as well, because if we talking about submission of flat file, not X12, it does change the section.
And then, of course, 180 calendar days, that could be a tight turnaround, depending upon the specifications of the flat file. If we have to create translators in order to produce the flat files, go through testing, do what we need to do to comply with the other regulations, like the restricting the reproductive information that maybe didn't apply before, but now that we're submitting data to CRISP may be applicable. So some of that work would need to be done within the time frame too.
So, so you're thinking that I'm trying to think about how the best word the timing, because if the regulations are proposed and they go through, there's an effective date. What did you have in mind if you think the 180 days is maybe tight? Would you say, oh well, this is the time frame we had in
mind? And I'll let other EHNs speak as well. I mean, I would think maybe at least a year to give us an opportunity to get this onto our roadmaps, depending on when the actual regulation drops, and to do a thorough review and coordinate with CRISP, because I'm sure we'll want to do testing and everything else.
Yeah.
Genevieve, did you have any thoughts?
No, we agree on a year. I think in additional to the technical, and we've mentioned this, and I will, the business associate agreement issue does not apply to every EHN. We do BAAs differently, each of us from each other, but I know we're not the only ones in this boat, but we will have to update every business associate agreement for every payer that we work with in the state. We will also, or even payers not in the state, because a patient could be using a payer who actually is not in Maryland, but they get their care in Maryland, and then we still have to share it. But we also, we predominantly work with channel partners on the provider side. And so we will have to update our business associate agreement with the EHR vendors and RCM vendors who are our customers, and they will have to also update their business associate agreement with their customers who are the providers. I'm also not clear whether or not MHCC has thought through the fact that provider organizations will have to update their notice of privacy practices. So if they are not currently stating in their NPPs that data is being shared with CRISP, because maybe they're not sharing data, they will have to update their NPPs to indicate that this data is now going to be shared, because otherwise patients have no notice of it. And so we're also concerned about like the downstream impact on provider organizations of having to update those NPPs. And like, our stance legally is we can't share the data with CRISP until our BAAs are in compliance and their flow down BAAs and the notice of privacy practices are in compliance, because otherwise we're violating HIPAA.
Very good points.
Yeah, these are good takeaway items. I think they're deeper discussions, and we have to talk with our AAG internally. But these are good comments to make. So thank you.
Eric, did you have something else you'd like to add?
No.
And I'm just wondering if it would help in working on this technical manual, if having that earlier would help with the timeline as well.
Helps with the technical. I mean, there's nothing really that you guys can do to assist on the contractual and legal part of it, right? That's just work has to happen. I think on the technical side, it potentially could shorten, but I'm sure most of us have like PI cycles that we use. And so we have to have like an opening in a PI cycle, which we obviously prioritize regulatory mandates in that. So.
Okay. Very helpful. Are there other questions that you all would like to ask that you haven't had a chance to talk about related to this particular regulation?
Really sorry, David. I feel like I'm monopolizing, but I'm just gonna keep doing it. But one of the things I'm sort of curious about that I don't know if it belongs in the regulation or in the technical guidance, but one of the things we're not super clear on is whether or not we will be signing a data use agreement with CRISP. Like, I know that there's this mandate that we have to share the data. But it's just not clear, like, if there has to be a data use agreement in place. And one of the concerns we have is like, under HIPAA, once we release the data, we're not liable for the breach because this is not a business associate agreement that we're doing. But there is still legal liability. So if the data gets handed off and CRISP has a breach, knock on wood, and I say that because I wouldn't wish it on my worst enemy at this point. If they have a breach, like, there are still legal liabilities from lawsuits that we're all going to have to deal with. And so, typically the liability limitations go into things like the data use agreement. And so I'm just kind of curious, like, how much you guys have talked through some of that and, what we can kind of expect around legal protections for us, and whether that's going to be in the technical guidance or whether it's a agreement of some sort.
And I'll just ask Nicole or Craig if they're able to comment at the stage, or if this is just a note that we take away and talk about.
Yeah, this is Nicole. I would love to talk to you about that separately. I know what we've done in other realms is actually have data use agreements and sort of, offer that as something we can do, especially for early implementers, right? It's easier to sometimes, be the first ones and say, this is what we need. And then we are happy to work through those things. I think what we really need from you all is, and I'm so grateful for this call, because we're getting it, but really need from you all, like, this is what we would need to feel comfortable. And I know from the CRISP side, we're always willing to work through that. We do that with our providers. We've done that with pharmacies on the non-CDS side of things. And then, of course, I can't speak from a regulatory perspective if it, comes down to being a regulatory requirement. But from the CRISP perspective, we're very willing to work through any data use questions you all might have.
Okay, thank you, Nicole. Genevieve, does that give you a sense of direction at the moment?
And I think we're open to having a conversation with you guys about it. I think the two biggest concerns for us, right, and you guys all understand why, is legal liability around lawsuits in particular. If there is a breach of some sort, right? And then the second would be limitations on reuse of the data for purposes that are not listed in the regulation. I think those would be our two biggest concerns. I think our lawyers are not very comfortable with handing off the data with no guarantees that it's not going to be used for something else once they have it.
Yeah, understood.
I think if your lawyers are interested, and again, we're so willing to have these conversations, and I think if your lawyers are interested in telling us what they would need, can't promise anything from the CRISP perspective, and of course MHCC is regulating, but if we can get like very clear requests on what folks would need to feel comfortable, I think we can work through those. I haven't seen at least, and I haven't been here since the beginning of these work groups, but I haven't seen at least sort of like, this is the concern and this is what would solve that concern for us. I've seen more of the high level concerns. So anything that you can provide with really, clear asks and direction, we're so willing to engage on that stuff.
And I think some of it comes, and I think for the technical guidance manual, one of my suggestions might be, in addition to the security of the transmission, having this amount of data is going to put a very large bullseye on CRISP for ransomware. I mean, that is just the unfortunate reality I've been living in since February. Because this is a significant amount of data concentrated in one location. And so in addition to security around the transmission, I think specifying what the data security measures are going to be once the data is within CRISP would be really important, I think, to all of us, which also goes hand in hand with like liability limitations, right? Like if we have assurances of certain security levels for things that like limits our legal liability from lawsuits. So there's, I think there's a number of things like that that would be really useful and make folks feel more comfortable with handing it off.
Yeah, absolutely. I mean, 100% understand those concerns.
Yeah.
So please,
Yeah.
you know, again, like I think this is super helpful for continuing the conversation. I think, you know, to the extent that there is, I know you all have been working through this for a list, so I imagine your attorneys have a list of concerns, and the more concrete they are and the more concrete, you know, the asks or mitigation strategies are, you know, we're so happy to work through those. So if you want to provide those over email, or if you want to have a separate meeting, yeah, just let us know. And I apologize, but I have to run at 2:00, but I know Craig is on, and very happy to engage over email.
So, Genevieve, is this a takeaway for you and Nicole offline?
I'll talk to our legal counsel. They may want to do it in the public comment period on the regulation or in a phone call. I'm not quite sure which. So let me have a conversation with them and we'll figure out. They might honestly do both is probably what they'll do, but I will talk to them about that. And I don't, if other EHNs want to jump in, I don't know if we probably can't get multiple legal counsels on one call.
Yeah.
That's probably would be difficult to do, but I'm sure others have some of the same concerns within their organizations.
Very good. Thank you.
Yeah, and I'll just throw this out. I don't know if it's probably been considered and shot down, but I don't know if de-identified data would meet the needs of the use cases that you defined above, since they are fairly open. You know, de-identified data would go a long ways towards solving many issues. So I just want to throw that out for consideration, if it's not already been discussed.
So, yeah, we've actually talked about it. So I believe Chris and maybe Craig, you can talk about this. So the data has to come to Chris in a way that they can, it can be de-identified, if you will, or encrypted, but it can be linked to other data. So the thinking would be that in order to do this data linkage, you're going to need to have identifiable information. And then for use thereafter, it's encrypted, but linked. Craig, any thoughts here?
No, I mean, I would just agree. We've discussed this. I think it depends on the actual definitions of the data use that were mentioned very early on in the conversation. But my understanding from the law and the intent behind the law is that, you know, this data needs to be linkable to other sources, like you just said, and then usable probably in a patient-specific context as well. So I don't think de-identified works.
Okay. Any other thoughts here before we move along? Okay, Anna.
Okay. So we've gone through the portion of the regulations that discuss the transmission of electronic health care transactions. So I'm going to go back to the slides so we can talk about some next steps.
Yeah, and while Anna's bringing it up, I would say this has been excellent feedback for us. So we appreciate everyone who's joined and either commented in writing or offered additional feedback today. So thank you for that.
So for next steps, staff will consider the feedback we've heard from today and also the comments we've received. And we aim to publish draft regulations in the register in the fall of this year. So be on the lookout for that. And before we close, I'd like to offer our Executive Director, Ben Steffen, an opportunity to share a few words. Ben?
Thank you, Anna, and I too want to, I think we've been thanking everyone since we got on at 1 o'clock today, but I want to thank again everyone's attention, and it's clear that people have gone through these I don't know how to characterize these proposed regulations. They're not quite yet proposed regulations. There's going to be more tuning, but the input we've gotten has been very helpful. I think some of the ideas that have been highlighted to us, we do actually have those implemented in other data collection initiatives that the Healthcare Commission or our colleagues at HSCRC embark on. But it's good to hear that you too are concerned about some of the same issues. We'll continue to engage the network community to talk about how we can get this into an operational state. Clearly, there are a lot of very important priorities that I've generally talked about at the outset that I think we think this information will be helpful for, but we also understand the concerns of the networks as well as the importance of federal and state law in considering as we move forward with this initiative. You'll hear more from us over the coming weeks as we move these nascent regulations forward. And look forward to your comments as well as your thoughtful commentary as we move through the process. So thank you.
Okay, so Anna, back to you.
Thank you, Ben. Thanks, David. David, is there anything you'd like to add in closing remarks?
No, I think we've got a lot to take away and talk about, and again, it's good dialogue to have. So your time was well spent for joining us this afternoon.
Thanks, everyone. And here's my contact information if you need it. Have a good rest of your day.
Take care, everyone.
Thank you.
Thank you.